Ms. Mulligan, are you back?
Yes, I'm here.
Great. Looks like we have all the board members. Matt Sutter, are you here? Matt? Let's give Matt a second. Okay, Ms. Mulligan, we can go back on the record.
You're on the record.
Yeah. We will resume our hearing of August 3rd. Next, we have the UVM Health budget overview and presentation. Mr. Sutter, are you providing an overview first, or should I turn right to UVM?
We are not. You can turn it straight to UVM. Thank you.
Okay. And Dr. Leffler, are you here?
I am here. Yes, and my team is here.
Great. All right. Well, then we'll turn to you. Nice to see you, and thank you and your team for being here, and we look forward to your presentation.
Thank you. Good morning, Chair
Actually,
Foster.
I apologize. Sorry, I think I'm supposed to swear you in or have our counsel swear you in. My mistake. Yep. Julia, would you mind swearing in the witnesses? And how we'll do it is, Julia, you can read the oath, and then each presenter from UVM can say their name and affirm the oath.
Yes, absolutely. Give me 1 second here. Sorry, let me pull it up here. Okay, thank you so much for your patience. So could is everyone who is going to be speaking have their cameras on?
I'm not Ramsey Harrington. I don't have access to turn my camera on right now.
Okay. So then, like Chair Foster said, whenever everyone, I'll read the oath, and whenever everyone gives the oath, they can go one at a time and say their name before they give the oath. So do you swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
Steve Leffler, I do.
Rick Vincent, I do.
Jessica Michella, I do.
Ramsey Harrington, I do.
Bradley Crumpf, I do.
Will
Jennifer
Clark,
Gagnon, I do.
Tom Galanka, I do.
All right, thank you very much.
All set, Chair.
Can folks hear me? I just want to make sure that camera access is given to Ramsey Harrington and Jessica Michella, please. They're both presenting today. Okay, thank you.
All right, Dr. Leffler, the floor is yours, and thank you all for being here.
Thank you. Good afternoon, Chair Foster and members of the board, and thank you for giving me time today to kick off our system's budget hearings. 10 months ago, I stepped into the role as CEO of UVM Health, in addition to my role as president of UVM Medical Center, because I believed I could help get us back on track. Back to being focused on our patients, back to being in service to the communities across Vermont, back to collaborating towards solutions to the healthcare challenges we currently face in Vermont. I am proud of our progress so far, but before I jump into anything else, I do want you to know that I fully appreciate the hard work in front of us and the urgency that we face. I hope you'll see that urgency reflected in all the decisions that went into this budget and the work we're already doing to ensure that we meet it. This is my first budget as a leader of this health system, and I want to speak to you plainly about what's in it and why. When I accepted this job, I promised this board, our lawmakers, and the people of Vermont an honest account of what I found. I've done my very best to keep that promise. This budget reflects months of hard decisions and a hard reckoning with what we've learned and what the liaison team found when they looked closely at our operations. I'm not surprised by these findings, but they're nonetheless significant and challenging. The liaison team's May 1st memo on revenue losses and physician productivity described a system that cannot sustain itself in its current form. We need to make significant expense reductions and improvements to provider productivity, and quickly. Getting this right means we can't just budget differently, we must work differently, right size, and implement new ways to deliver care, more efficiently and affordably. To get us there, our budget is built around three things: access, quality, and affordability. They are the test for every decision that went into this budget. Are we making it easier for patients to get the care they need when they need it? Are we improving the quality of that care? And are we doing it in a way that helps Vermonters afford the care they need? Affordability is a particularly urgent priority at this time, and one with implications for not only our patients, but our staff as well. To reach $300 million or more of expense reductions over the next 3 years means impacts to our staffing. You've already seen impacts to our staff over the past several months. The difficult reality is there is more coming. As someone who spent their entire career at this place, as a physician, and now leader of the state's largest employer, I can't tell you how much the impacts on our staff bothers me. The staff we are impacting are all doing important work. These reductions in force impact great people and their families. I apologize to every person impacted by our staffing changes. As an organization, over 60% of our expenses are in staff salaries and benefits. That means we can't accomplish restructuring of the magnitude outlined in the liaison team report with just executive pay reductions, supply chain, and equipment savings alone. It is important for us to reduce spending in those areas too, and we are, but that's only a start. As we begin to reduce our expenses, we first at administrative cost savings, finding ways we can lead with a leaner team. And we will continue that trimming those positions along the way. More and more of our leaders, including me, are wearing multiple hats. We're also looking to reduce operational redundancies, where we have a real chance to more fully integrate as a system to achieve better patient outcomes and reduce waste. We are also exploring opportunities to use technology to do more work more efficiently. We're doing everything we can to avoid impacting direct patient care roles. But the fact is, everyone at UVM Health are patient care providers. Because even if we aren't doctors or nurses or medical assistants, everyone who works here supports the provision of healthcare. We cannot serve our patients well if we cannot get them scheduled, help them navigate our buildings, or make them aware of critical public health information. No matter where we reduce cost, there will be impacts felt by our patients. Please know we're doing everything we can to limit those impacts as much as possible. One way we're doing that is by strengthening our partnerships with hospitals and outside organizations to do one of the most powerful things we can do in healthcare: deliver the care patients need in the lowest cost setting closest to home. You'll hear more about our efforts to partner and provide fractional specialists to Vermont hospitals that are not part of our system, expanding access to our academic expertise throughout the state. I believe you'll also hear from some of my hospital leader colleagues at places like Gifford and Rutland about how they are keeping more inpatients who do not need tertiary level care. That helps keep costs down, supports those hospitals, and is what's best for those patients. What I hope you see in this budget is not business as usual, or more of the same from UVM Health. I hope you see the rigor in how we got here, transparency in what we're showing you, and the heart in why we're doing it, even when it's a hard decision. I hope you see and feel a shift in this year's hearings too. The team here today is comprised of people who care deeply. Some you know, and others you're meeting for the first time. They've been asked to lean into hard questions, offer responses that attempt to get at the heart of what you're seeking to understand, and demonstrate to you that this team prioritizes our patients, each other, and the communities we serve. This work only matters because of the people it impacts. A patient waiting for a bed or transfer, a child who needs specialized care that is currently only being provided at UVM Medical Center in Vermont, a patient who receives the preventive care she needed, avoiding a major illness. Every decision was weighed with patients in mind. As you know, this budget and the work ahead doesn't solve everything for us. We are still in the early stages of a multi-year effort to reduce expenses by over $300 million and reshape how we serve our patients, our communities, and our own employees. We agree with the liaison team that our expense reductions can't end with the initiatives that are already reflected in this budget. We need to find even more savings over the course of the coming year, approximately 50 million more in savings. The bulk of that work to find those savings is still in front of us. I want the board to know we are committed to doing that work in partnership with you and others. We've worked closely with the liaison team through this process. As they look to conclude the bulk of their work at the end of September, I want to acknowledge their public service. Stephen, Nancy, and Mike have given us a helpful and valuable expert outside perspective to help us chart our path forward. Thank you to each of you. I'll now turn it over to our CFO, Rick Vincent, to provide a system-level overview of our finances. He'll talk about how we're doing financially in FY26 and discuss some of the work we are doing to reduce our administrative expenses across UVM Health, including both savings we've already achieved, especially in shared services, as well as the difficult work that remains ahead as we look to further reduce administrative expenses at all levels of our system and hospitals. At your request, Jessica Michella will share the work of our Population Health Services Organization, or PHSO. I do hope that discussion serves as a reminder of the importance of providing what we call high-value care. I continue to believe strongly that value-based care and population health management remain the future of healthcare reform, despite the headwinds reform faces outside of our walls. Finally, our medical group is currently undergoing more change than probably any other part of our health system. That change is as difficult as it is necessary. It's a key component of our efforts to improve both affordability and access. I'm proud of the work the team has done so far. We are clear-eyed about just how much more is still ahead. Dr. Ramsey Harrington will walk you through those efforts in detail because those are key components to each of our hospital's budget presentations, which you'll hear on Wednesday. Thank you again so much for allowing me time to speak today. And with that, I'm going to let Rick take it away for our finance presentation. Thank you.
Thank you, Steve. I think, Jen, are you pulling up the slides? So while the slides are coming up, I just want to start by thanking the Green Mountain Care Board staff for their partnership this past year, and also for sending us the outline for this presentation ahead of time to ensure that we covered the topics that the board was most interested in. What I'll do today within that framework is spend some time providing a high-level overview of both UVM Health Network finances, as well as some of the efforts we're making at the system level to improve affordability, mostly through expense reductions. And as Steve said, doing so while still building access and quality. In particular, I'm going to focus on the efficiency gains and expense reductions that we've generated in our shared administrative services. And then I'll hand it off to Ramsey and Jessica to talk about the medical group and the population health service organization. I think you can skip a few slides, Jim. Next slide. So at the UVM Health Network, we take the financial stewardship of our organization very seriously. As Steve said, we're focused on making the care we provide more affordable, and we'll be talking about that today. We also know that in order to carry out that affordability work, we need to do that within a financial framework that ensures that we are sustainable. This means that there's real urgency to our expense reduction work because we can't keep losing money from operations if we're going to be here for 5 or even 3 years from now. So as a result, we do have performance targets that are based on rating agency A-rated medians that signify a financially stable organization that we continue to strive to meet. Slide, Jim. So this is our 5-year financial framework that we update every January that we provided in our last several budget filings. For FY26 and 27, you can see there's a couple cells highlighted there, which is meant to signify that really our focus in those 2 years is to lower our expense base to meet the lower commercial revenue that we're now experiencing to get back to break-even margins. Even though those targets are below the targets that you just saw on the previous slide, we need more time to get back to profitability. In terms of days cash on hand, you can see that it's pretty much flat in the framework going out the next 5 years. We're essentially just trying to maintain our current days cash on hand. In FY26 and 27, we're going to be focused on making just the minimum capital investments that we need to make to ensure that our days cash on hand don't fall even further below these targets. In the last column there on the right, you see that our framework assumes $1.1 billion worth of capital spend over the next 5 years. I just want to highlight that number is completely predicated on us achieving our margin targets. If the margin targets are not achieved, then we obviously won't spend that amount in capital. In terms of debt structure, that's a place that we're actually in good shape after years of being very careful with how much debt we've taken on. You can see that the debt to cap ratio at 30% actually goes down over time if we do meet these margin targets. If that does happen, we will use some of that debt capacity to make up for the capital investment backlog that we generated the last few years. I just want to point out that even through this period of time, it's very important, I would say critical, that we maintain our A rating so that we do maintain the access to low-cost debt that we've built into this financial framework. The staff asked us to share what the default provisions are on our debt in this presentation, so I'll speak to the 2 default provisions that we have. First, in terms of the publicly held debt, we do have a new master trust indenture that was put in place in August of 2025, where that default provision is 2 consecutive years of the debt service coverage ratio being below 1. So that's, if you look at that capital structure section, it's the second line in that chart. And then we have an additional default provision on our bank held debt that uses days cash on hand as the measure, and it's measured at the end of September every year, and that needs to be above 75 days cash on hand. We know that we can't get to these targets all in 1 year, particularly when we're focused as we are on making the care we deliver more affordable. But we do need to get to these targets to ensure that our organization is financially stable. Slide, Jen. So as you know, and as Steve shared, we've been working very closely with the liaison team this past year, and I do want to echo Steve's comments. It's been incredibly helpful to have Nancy, Mike, and Steve help guide us this past year. In addition to their efforts, we worked, as you know, with Alvarez and Marcel, and they forecasted patient revenues that are going to fall short of expenses by over 300 million over the next 3 years as we all work to bend the cost curve. We've taken that financial forecast very seriously and have put into place initiatives that we expect to improve affordability by that amount over the next 3 years. As you see in this chart, the vast majority of the measures are expense reductions. We've already built $100 million in improvements into our FY26 run rate, which won't be enough to allow us to break even this year, given the significant drop in revenue that we saw in January. We built another $140 million in affordability improvements in our FY27 budget. It's important to highlight these categories are high-level categories. There are many, many initiatives within these categories that are already well in flight. Some of these are within our hospitals that you'll hear more about on Wednesday, and then some of them are in shared services, administrative shared services, the medical group, our population health service organization, which we'll talk about today in this presentation. Sorry, next slide, Jen. Before we dive into the FY27 budgets, I thought it'd be helpful to ground us in the present. So this is how our 3 hospitals are expected to finish FY26. When we submitted our projection on July 1st, it was based on our year-to-date April results and the margin improvement initiatives we had in flight at that point in time. We still have significant amount of work to do and ground to make up to get to those projected year-end results. And if we do fall short, that will have to be made up in FY27 and 28, as we still need to get on that run rate that is a $300 million plus improvement over where we stand today. Just want to note that the numbers you see here for CBMC, that this does include the nursing home, which is Woodridge. For Porter Hospital, this is just the hospital, since the Helen Porter skilled nursing facility is under a separate tax ID number, not regulated by the Green Mountain Care Board. You can see here that we anticipate that we'll end the year significantly in the red at UVM Medical Center and at CBMC. The reason is fairly straightforward. The revenue reductions have happened very quickly, and by contrast, our expense efforts are taking longer to implement, particularly as we implement them as quickly as possible, but in a way that creates as little negative impact as possible on our patients and our employees. Slide, Jen. This slide shows the entire UVM Health partner margins. It also shows the data a little bit differently in order to isolate our hospital operations from our skilled nursing facilities. This is also how we monitor performance internally. Our skilled nursing facilities are in the red, as you can see on the bottom line of the chart, and are likely to be there for the foreseeable future. But we know that virtually all nonprofit nursing homes are in the red, but that does not mean that they don't play an incredibly important role in the continuum of care in our system. What this also shows is that our critical access hospitals, Porter, Alice Hyde, and Elizabethtown are producing positive margins, and they're expected to do so in the future. Our community hospitals, which are CBMC and CVPH, show different trends. CVPH is now in the black, and we have more work to do to get CBMC back to that point. Finally, our academic medical center, the top line on that chart, UVM Medical Center is significantly in the red and has the steepest climb back to profitability. I do also want to point out that all three of the New York hospitals that you see on here are expected to generate a positive operating margin this year. This is a really big deal and is the result of a lot of really hard work and difficult decisions by our New York teams. I can honestly say that our New York hospitals are the brightest spot in the system's financial picture right now. And then finally, this improved performance is what is driving the fact that the due from New York balance did not grow this year and is not budgeted to grow next year, which we'll get into in a later slide. Next slide. Now we'll spend the next few slides showing how we're doing in managing administrative shared service costs. So our goal, like every system, is to spend as little as possible on administrative costs while still providing all the support that our caregivers need. And we've made significant progress towards that goal. Shared service expenses as a percentage of total expense has steadily declined and will do so again next year. Even when you look in terms of absolute dollar amounts, there's been a decline. And when you adjust for inflation, there's been a very significant decline. In the FY27 budget, the expense per total will be slightly below the strata median, which is the guide that we've used the last several years now. We're really proud of this work, but we know we still have a tremendous amount more work to do in this area. The network supplemental included a glossary of what makes up the other section on this chart, which is the other shared services, but just to highlight them once again, it includes all our network-wide clinical leadership teams. So it includes the teams in pathology, in lab medicine, radiology, pharmacy, our clinical chairs. It also includes other clinical costs, such as our regional transport operation and our outpatient pharmacy operation. Lastly, it includes our UVM affiliation costs, depreciation on system-owned assets, and interest expense on system-owned debt. So for that category, you can see there has been growth, and the growth has been primarily connected to our outpatient pharmacy operation, which is what has enabled the significant growth that we experienced in outpatient pharmacy revenue, which you've seen in the hospital budgets the last few years. Next slide, Jen. This is a breakdown of the shared service allocation, which is the combination of both administrative shared services and other shared services. The allocation has been based on total revenue, and that continues to be the basis for the FY27 budget. Next slide, Jen. This shows a few different ways to examine the labor trends within shared services. So for administrative shared services, which is at the top of the chart, you can see that FTEs have been declining, which is the major driver behind the decline in costs that you saw on the previous slide. Other shared service FTEs have been growing. Again, this is primarily due to the growth in our outpatient pharmacy operation. The use of contract labor has been declining. And then finally, the cost per FTE has been going up, which is in alignment with the general salary inflation that we've experienced the last few years. So connected to the 300 billion plus improvement that we need to achieve by FY28, these at the top part of the chart, these are the cost reductions that we've included in our FY27 budget. And at the bottom are the areas that we're targeting and already have plans in place, as Steve highlighted, to generate cost savings that go beyond our FY27 budget. So the presentation outline asks us to speak to how we compare to budget guidance benchmarks. And while there are none that are specific to the UVM Health org, we thought we would cover the out-of-state subsidy benchmark that is connected to UVM Medical Center in this presentation, as UVM Health has significant influence on the achievement of that benchmark. So I'm pleased to report that the due from balance between Vermont and New York is not projected to grow in FY26, and we're not budgeting for it to grow in FY27. However, the balance does remain at 105 million. Thus, we're not meeting the out-of-state subsidy benchmark, and a 1/5 tax needs to be applied to that budgeted balance. When UVM presents its budget on UVM Medical Center presents its budget on Wednesday, you will see that we've incorporated all this information into the applicable commercial rate benchmark per the Green Mountain Care Board guidance. And then the last piece for me, the Green Mountain Care Board staff asked us to provide one last update on One Care Vermont, since there will not be a separate One Care hearing this year. So to start, this is a summary of the final 2025 program settlements. So starting at the top, the Medicare program, unfortunately, will experience its first shared savings loss. The Medicaid program will experience a small loss as well. But as you can see in the note there, the fixed payments are actually ahead of the shadow claims, so that will help to offset some of that shared savings loss. The MVP QHP program is going to generate shared savings and will earn the quality incentive bonus. Related to that, important just to highlight that even through 2025, there was steady improvement in quality results since the end of the pandemic. So really good work on the part of the One Care participants. And then finally, we communicated this earlier this year, this summer, I should say, but we did distribute the $11 million back in June to the non-hospital affiliated primary care practices. And then this is a summary of the high-level wind down of One Care operations. All substantive business will be done by this fall, with only a few minor closeout functions that will be completed by April of this coming year. So with that, I'll now hand it over to Jessica to share information on the Population Health Service Organization and payer contract negotiations.
Thank you, Rick, and thank you to the board for having me today. It's my pleasure to share an update with you and details about our Population Health Services Organization, and my honor to work alongside the team that does this great work every day. By way of brief background, UVM Health established a Population Health Services Organization we often refer to as the PHSO in late 2021. It's important to note that it does take several years for a Population Health Services Organization to come up to speed and be able to provide the efficiencies that I'm going to talk about today. The goal of establishing that organization is to provide centralized resources and integrated operational support to our primary care practices. You can go ahead and move to the next slide. Thanks, Jen. Centralized clinical and administrative resources provide economies of scale, equity, and operational consistency ensuring that population health programs and services are standardized and applied consistently across 31 UVM health primary care practices. It's important to note that the PHSO is not a separate entity. The PHSO works separately, directly, distinctly with primary care teams. So it's an extension of the primary care team. And the PHSO works directly to improve patient outcomes and value-based performance, enabling the clinic-based teams to focus on patient care and day-to-day patient operations, while those specialized population health teams coordinate outreach, proactive care, and quality improvement initiatives. Overall, the Population Health Services Organization for UVM Health manages 154,000 lives across those 31 adult and family medicine primary care practices and 2 direct-to-employer contracts. Jen, you can move to the next slide, please. The PHSO has supported ambulatory quality performance for the system for the last 3 years. We select key metrics that internally align with value-based contracts as well as national standards, and we do an annual review and metric setting with primary care leaders, taking into account the important clinical measures. So what's most important clinically, we also integrate into this setting. We set ambitious targets based on industry-led expectations and are providing system and provider level performance dashboards and scorecards monthly. The PHSO uses these tools and this data to identify opportunities and then works directly with primary care to support panel management and practice level performance initiatives. So for example, we noted that we weren't doing as well as we wanted to on the depression screening and follow-up measure. When we did a deep dive into the data and in conjunction with primary care, we realized that it wasn't the follow-up that was a problem. We were doing as well on the screening. And so we decided to increase the visit types that included depression screening, which then increased our performance in this measure. Another example is that the population health team, in conjunction with primary care, developed hypertension management protocol. And this included acute in-office blood pressure, home monitoring, and medication titration. As a system, we see system-wide improvements across all of our quality measures relative to the prior year and sustain improvement over multiple years. This is going to position UVM Health to achieve top-tier quality benchmarks. While there's still progress to be made, we're really proud of these results. And we know that when we perform well on these metrics, our patient population is healthier and that reduces expenses to the system. Next slide, please, Jen. Population health management ensures that primary care access is optimized for the right patient at the right time with the right resources. The PHSO enables this optimization through a number of workflows, programs, and resources, including analytics and risk stratification. So when we look, we want to know who do we need to see and why, so that we can implement panel management, which is our proactive outreach to patients to support those with identified needs. So for example, we may look in that data and see that we have patients that have no visit scheduled. And we might want to prioritize the patients who don't have a visit scheduled, who have an unmet care gap, like they haven't had a blood pressure taken, or they're diabetic and they haven't had an A1C drawn. So we're able to look across the data and help manage that panel and be very proactive about getting the right patients in with the right provider at the right time. Medicare annual wellness visits is another good example. We have a centralized nurse-led program that provides remote visits to improve annual wellness performance while freeing up valuable PCP time. And that time is for that provider-patient time. And we know that PCPs need more of that time. In the last year, the centralized annual wellness visit program has freed up 7,500 hours of PCP visit time. We also have post-discharge follow-up and transitions of care structured centrally. Those are timely nurse-led outreach, post-discharge visits to assess and schedule follow-up needs with providers to avoid admissions and unnecessary ED visits. Our care management programs provide episodic and longitudinal engagement with nurses, social workers, and community health workers to support health-related social needs, chronic disease management, and mental health. Case management supports these patients asynchronously and reduces the burden on providers to support these important but time-intensive patient needs. Next slide. Now I'll transition to talk a little bit more about our contract negotiations with payers. Next slide, please, Jen. UVM Health is committed to implementing all rate changes that are compliant with hospital budget orders. While taking these steps, we are in active support of our shared affordability goals through the advancement of value-based contracts. Central to this work is our collaboration with commercial payers to develop models that strengthen accountability for quality, patient outcomes, and total cost of care, rather than contracts that address the volume of services. We are in active discussion with commercial payers around value-based contracts. In addition, as a part of this effort, we are partnering with commercial payers to transition towards a more Medicare-aligned reimbursement methodology. Greater alignment across payment systems creates a more sustainable framework that is predictable, and it's a proactive step towards reference-based pricing. I will now transition to Dr. Ramsey Harrington.
Thanks. Chair Foster and members of the board. Over the last 10 months under Dr. Loeffler's leadership, UVM Health and our medical group have altered our tack, and in so doing have taken on some significant changes. We're making these changes for the benefit of those that we serve, and they're primarily designed to improve access for patients in our communities by increasing our clinical capacity. As I'll discuss today, we'll accomplish this by both maximizing our current resources and by securing the workforce to meet the clinical needs of the region. I'm going to speak to what's changed, what the early data tells us, and where we see substantial opportunities for us to improve in FY27 and beyond. Before I review that hard work of the folks that I'm representing today, those individuals deserve my gratitude and recognition. There's over 1,500 clinicians, and there's thousands of nurses and staff that are changing their workflows, they're absorbing new information, and they're adapting to a pace of change that this organization has not experienced in the 20 years that I've been here. I also want to thank the liaison team for what's felt like a true partnership with us in selecting a consultant that had the necessary expertise and helping keep us accountable to moving with pace, and in leading with curiosity to understand the challenges and the associated complexities of operating a medical group in 2026. Next slide. When we selected Alvarez and Marcel, I was hopeful that they were going to make some just practical suggestions to support our clinicians to make it easier to practice, to free up time to see patients. I had been in this role for about 6 months as that engagement had began, and I'd already gathered some information from other academic medical group leaders from around the country. And I was anticipating recommendations about clinic space, staff support, technology enhancements, maximizing GME complements, improving OR and procedural access, all the drivers of really highly productive medical groups. But as the weeks progressed, A&M made it clear that, although all those elements are going to be important, we first have some foundational work to do, as noted on this executive summary slide. Our clinical and administrative leadership teams embrace the suggestions and partner with A&M to provide information and support the work that led to their final recommendations. The medical group board of directors and then subsequently the UVM Health Board of Trustees both unanimously endorsed the recommendations and the timelines that we set forward, which led to an implementation start date of April the 9th, affectionately referred to as day 0 inside of our teams. The work since that date's been led by our system chairs and their administrative dyad partners. Before we move and dive into the data behind the work, I want to acknowledge that our FY27 budgets preceded implementation of many of the changes that are currently reshaping the medical group. At the time our budgets were due for submission, we didn't have much of the data as it relates to the A&M recommendations. For example, like how many clinicians would accept the additional hours and how many would choose to reduce their clinical FTE. And as a result, and as I'll speak to a little later, we're still getting a handle on how much ambulatory time is going to be added across the system with the changes we're making. With that in mind, what is in our budget is an accurate representation of a point in time, and I'm grateful for the opportunity to discuss the work that we're going to move through and are moving through quickly, and we're learning more every week. Next slide. It's been less than 120 days since April the 9th, and we've implemented close to all of the A&M recommendations on that aggressive timeline. And we're now in the process of auditing our work, assuring that we can fully transition from implementation to adoption. And I'll say it again, this work is the right work to do for our communities, and it's not been easy on our teams. We will keep moving forward because of the important results it's going to yield for those that we serve. Next slide. Access. We recognize that our access challenges at UVM Health are longstanding. In my personal clinical work, those challenges have been progressively on display during nearly every shift for many years. But under Dr. Leffler's leadership, I can now assure the board that this is a top priority for our organization. And coupled with the A&M recommendations, we've got the beginning of a path to secure alignment of mindset and resources inside UVM Health. Next slide. You've heard Dr. Leffler say this before, and it's worth repeating. We want to exceed national norms when it comes to access for care. And for that reason, we're beginning to change our internal reporting to align with national benchmarks. That's going to be a theme for a few slides here. This is true for access measures as it is on this slide, but also for productivity measures. The data here is really intended to provide transparency to the board for what we are keeping ourselves accountable to and to demonstrate the aggregate access against national benchmarks for our Vermont hospitals. Next slide. And here you can see the breakout per hospital year to date for FY26. As we continue to integrate as a health system, though, I think it's important that we spend a moment looking at the data by clinical service. Next slide. Most of our system clinical departments have ambulatory services. And here you can see access to those services as measured by new patient visits within 14 days by department compared to national benchmarks. Greens are performance in FY26 actuals. Blue's the benchmark. I will reinforce that this data is FY26 actuals, which is why it differs from the 2 weeks of data that we submitted to the board. And I also want to highlight that I think it's important to share national benchmarks here for reference, which is not something that we've shown the board previously. Take home point, though, as you can see, we have significant opportunity in most of our departments, and I'll restate that our goal is to exceed these benchmarks. Although we continue to talk about the A&M recommendations as work to increase provider productivity, this is where our patients will actually feel the impact of that work. Centralizing control over template changes, increasing ambulatory hours per clinician FTE, overhauling our referral management is going to improve our performance. Said differently, as we maximize the number of slots in the schedules of our employed clinicians for patients, and we make it easier and more efficient for our patients to actually get on those schedules, we should see a greater percentage of folks that need new patient visits getting in to see our clinicians in a satisfactory window. Next slide. Referral lags. Another area where we have not historically met the expectations of our patients and referring providers is getting referrals booked in a timely manner. This has been a significant pain point, not only for our patients, but for our staff and referring clinicians, both inside and out of our own medical group. And this is another area that captures my attention in my own clinical work. Most of these patients have a new symptom or a new diagnosis, discomfort, and very frequently anxiety about the unknown. So delays in getting an appointment on the calendar are really hard on people. I will say thanks though to some recent changes in IT, A&M highlighting the pain point, and new alignment internally, we now have a path to fix this issue. And this month, we're embarking on a series of changes to refine referral management and scheduling work. This is foundational not only to our patients, but to UVM Health at large. Next slide. Okay. Specific to expanding ambulatory clinic hours, we move forward with standardizing ambulatory specialty schedules to 36 patient-facing hours per week. Again, a huge area where I need to thank those that I'm representing today, because this is real change for them and in many cases for their families and obligations outside of work. I mentioned earlier that we're meeting most of our aggressive implementation timelines. This is one of the areas that we postpone implementation by a month to hopefully, allow folks a little more time to accommodate childcare, elder care, and all those non-work responsibilities in our lives, or to decide to reduce their clinical FTE really can't. Next slide, please. So these new schedules went forward on July 20th, and we're in the process of auditing the final data from this improvement, and we can report that impact back to the board when we have it verified. I'd hope to have an actual impact number for you to show the increase in clinical appointment hours for this presentation, but with the clinic changes less than 2 weeks in, the data is still pending here. Next slide. When A&M took a look at our clinical operations, another major finding in the report was the volume of clinics that were moved around due to clinician cancellations. Digging into this data further, we recognize that there are actually some really appropriate reasons for cancellations. For example, the need of our surgeons to get into the operating room with short notice for an urgent need, or a challenging call night where a clinician works through the night, or appointment cancellations to actually move a patient up in the schedule for a pressing concern. But unfortunately, when appointments were canceled on our end, our staff have not historically delineated the reasons for the cancellations. And obviously determining what the true opportunity for avoidable cancellations is dependent on clean data. For that reason, we're improving our documentation and options for cancellation reasons for our schedulers, which should allow us to find some areas of improvement, and those changes are live now. With that said, early indicators demonstrate that the schedule change lockdown that went into effect improved the data point by roughly 1%. May not sound like much, but a 1% improvement translates in a group our size to roughly 4,500 fewer cancellations. Another area where we'll report back as needed to the care board as the data becomes more valid over time. Next slide, please. Okay. Having spent the time thus far discussing access from the patient perspective, I'll now turn to the impact of these operational changes on provider productivity as measured in terms of WRVU performance against benchmarks, and as it relates to our FY27 budget. Next slide. Moving left to right on this slide, here you'll see our aggregate WRVU production in 24 and 25 actuals, our 26 budgeted WRVU, in blue our FY26 year-to-date annualized, and in light green our FY27 budget. And in that far right table, the volumes for each column is then divided by our total clinician FTE, inclusive of both our physician and non-physician clinicians. It's important to note that the overall WRVU production of the group, as you see, continues to increase, while the overall average of WRVUs per clinical FTE remains pretty flat. This occurs for several reasons. Our goal is to improve productivity at the individual clinician level, which is a different metric than improving the productivity average for the entire group. In fact, with an increase in our APP to MD ratios over time, which is one of the key A&M recommendations, we predict that this average may actually decrease even as productivity towards the median increases at the individual provider level. Next slide. Okay, next two slides are intended to show where we are by clinical department and highlight where we have opportunity to improve. Reminder that this reflects FY25 actuals. But as this board and the liaison team have pointed out, clinical productivity across UVM Health has been below national medians. I'll again note that given the timing of the A&M recommendations as compared to the timeline of building our budget, we do predict improving clinical productivity in FY27 as compared to the FY27 budget submission, just based on very early data that's coming in from the operational changes that we're making. I'll also make note that these are obviously aggregate performance numbers by department. We have many individual clinicians that are performing well above the median benchmarks, and therefore, of course, have many others that are below our targets. Some of these clinicians that are beneath targets are practicing in clinical areas where we're unlikely, even in the most ideal conditions, to reach median. But we have other clinicians that we believe have the opportunity to exceed those targets and therefore reach our goal of median by department. Next slide. Okay, this slide to show the same departmental performance by our Vermont sites. And the slide illustrates some areas where we have clinical coverage needs, but where volumes may not allow us to reach median, but also some areas where improvements will likely take us beyond median targets. Next slide. Recruitment and retention. So recruitment of high quality clinicians has been a core priority under my leadership as medical group president, and I've put an equal emphasis on retention. Recruitment's critically important because the A&M recommendations provide a path to improving utilization of our current capacity. They don't provide a path to fully solving our access challenges in the region. It's the combination of these efforts that's going to allow our Vermonters to attain the experience that they're looking for. Ready access to best-in-class clinical care. Next slide. Here you can see our success in recruitment year to date during FY26 in an increasingly challenging national market with, very well-known supply and demand mismatches. As you've heard Dr. Leffler say, our clinical teams are our most valuable resource, and none of what we do is possible without them. I would like to thank our system chairs and their leadership teams for prioritizing recruitment over the last 18 months, in addition to our recruitment staff that have made our processes and the applicant experience just much more fluid. Next slide. Success in recruitment loses its value pretty quickly without success in retention. We historically have been challenged in retaining talent within the medical group, and happy to say that trend has improved slightly over the same time period that our recruitment has improved significantly. This trend will be critically important to follow in FY27. As the FY26 data that's in front of you, it precedes all the changes that we've discussed earlier today. Our A&M consultants clearly advised us that the operational changes that we're putting in are putting increased pressure on our clinicians and should be expected to result in the departures of up to 10% of our clinician workforce. If we can't beat that prediction or outpace it through recruitment, our performance to budget and, much more importantly, patient access will be negatively impacted. I am proud to say, though, that today our physicians and APPs have remained engaged and dedicated to all this access improvement work for all the right reasons, and we haven't experienced the predicted uptick in departures so far. Next slide. I wanted to highlight the importance of the medical group, not only to the hospitals inside of UVM Health, but to the state as a whole. My teams have had many conversations with our organizations across the state, sometimes and particularly initially led by our partners at AHS. It's imperative that the medical group positions itself to support our smaller hospitals and healthcare organizations across the region. Our provider recruitment department and our academic branch should not be considered just an asset to UVM Health, but an asset to the entire state of Vermont. Next slide. Many of our clinicians daily make themselves available on demand for our colleagues across the state. The services noted at the top of the slide here are not inclusive. This clinical effort is time consuming, particularly for several of these services, and in current states, largely not billed and not reflected in provider productivity. We budget for the effort, but we haven't generated revenue from this work to date. With some progress made by our new IT leadership, our ability to assist our colleagues and patients outside of our catchments will be easier through other technologies, including via electronic consults and telemedicine. In fact, again, a rolling theme here, things are moving. From AHS just this morning, received a notification of intent to help support expansion of our telehealth program through the Rural Health Transformation Support, which should speed our ability to provide tele-ICU, tele-oncology, telestroke, and teleneurology services specifically across the state. In addition to that, we're committed to support outright recruitment for inpatient care as called upon. Next slide. On that note, this slide demonstrates a baseline to the effort to help bring providers directly to our Vermont partners outside of UVM Health. It's been a key priority of mine to expand the support where needed. Our connection to the Lerner College of Medicine and environments with medical student and GME learners is a huge advantage for recruitment and retention in the current national environment, particularly for physicians. And I'd like to be able to leverage that draw for our colleagues across the state. And I want to be really clear on this next remark. We're not looking to compete. Where others can provide high quality clinicians to serve Vermonters through their own hospitals, for example, that's great. In fact, we've had several conversations with outside partners just to give recruitment tips and service redesign advice so that they can be successful in recruiting and employing their docs. We welcome any and all conversations that support our common goals to help all Vermonters. Next slide. You know, part of the reason we've taken an aggressive timeline for the A&M work is the urgency of the need to improve access for our patients. But there's another important element. There's a lot more work to do to get us to where Steve is leading the system. Next slide. Our budget submission includes some financial progress specific to the A&M recs, but there are elements that require longer timelines to realize. As a specific example, we need to continue to work with our bargaining units to move the needle on some of the bigger economic opportunities in the recommendations. For the financial opportunities reflected on this slide, we are committed to matching our efforts toward realization with the unified liaison team, care board, and UVM Health leadership desire for speed of execution. Next slide. Last slide from me. Finally, before you is a summary of work ahead in the medical group in FY27 that is going to build upon those A&M recommendations. As I stated earlier, the A&M engagement informed how to maximize access for the resources we have, but the goal of the medical group is to fix access to care for Vermonters. In that left column in front of you is the A&M work currently in flight or immediately ahead. I'll speak only to the last bullet about next steps. Soon we're going to need to assess the operational bottlenecks that will surely arise as we increase patient throughput. For example, I anticipate that the increase in volume of clinic patients, particularly where we're adding visits into templates, is going to drive a need for clinic support in areas. We're already seeing some early signs of that over the last few weeks. And as we add patient visits to our specialty clinics, we're going to need to rapidly assess the availability of procedural space to find efficiencies where we can and expand where we must. The middle column in front of you is about strengthening our clinical workforce. I spoke earlier to the need to continue to recruit and retain. We know we have several key areas where we have to recruit into unmet clinical demand. We also have areas where recruitment in one department will be necessary to provide access in other areas, anesthesiology being, the most obvious example. Increasing our APP ratios is recommended by A&M. It should increase access and speed of access when they're additive and maximize the utility of our physician workforce. We see opportunity in learner expansion across all areas of healthcare trainees, and we know that we have high quality clinical environments across our system and perhaps also with our community partners to absorb more learners. We also know that we lag other health systems in maximizing the opportunity for GME program expansion, and that work will begin in a year ahead. The medical group must also create specialty-specific APP transition to practice programs for sustainability and then maximize our APP contributions to the collective clinical mission. And finally, in that middle column, as noted in the memo and as we've learned from other high-performing medical groups, there's opportunity to improve alignment between compensation and productivity and to align system priorities with our compensation plan. The liaison team had an opportunity to meet with our compensation subcommittee recently, and our medical group board grabbed this topic in the last 2 weeks. Finally, that third column there is the work to contribute to our colleagues and patients, both in and out of our direct catchments, and the work to raise the bar for our patients and their families. And this includes a number of changes and specific initiatives to align the medical group to help our partner hospitals improve in quality performance. As an example, just this morning, we went live with our mobile integrated health program to support congestive heart failure patients in their homes to keep those patients healthier and out of our EDs and inpatient units. So with patients at the center of our work, the system chairs, our administrative leadership, and I look forward to leading the execution of all these improvements we have planned in FY27. Thanks. Steve, I believe I'm coming back to you with this. Yep.
Yes, thank you. So next slide, please, Jen. So since April of 2025 through this fall, we worked extensively with the liaison team. I would say after September, we worked hard to be more open and transparent and try to collaborate with them and learn as much as we could from their expertise. We were focused on the UVM health internal budget process, the GMC budget submission process. You've already heard a lot about physician productivity, capital budget and major projects. We've worked with organizational structure, shared services. I'm not going to read them all, but you can see they've looked at many different areas of our operations. And we've worked hard to understand the recent memos. And I want you to know that we're in alignment with what their comments are and the work we believe we have to do together. Next slide, please. So with that, that completes our presentation. I want to thank you so much to all the presenters, and we are ready for your questions, Chair Foster.
Wonderful. Thank you for the presentation and for everyone's hard work on putting this together. I'm going to turn to their board members first, but I did want to comment that this is obviously a very stark change in approach and partnership with the board, and I want to thank you for it. It's a big departure from, I think, the first couple of budgets I worked on. There's a lot of humility in this presentation. There was a lot of accountability. There's transparency, and there's some leadership and effort to work with the state and with other partners. So I just want to note that there's been a change in approach, and I recognize it. Nonetheless, we have to do our jobs, and there's a lot of hard questions that we have, and there's a lot of diligence that we need to do as the most important player in our healthcare space. And we will do that as well. But thank you for a different tone and a different approach from prior years. So I will turn it to Member Walsh for any questions or comments he has.
Thank you, Chair Foster, and thank you, Steve and the network team. I'll just second the chair's comments. I appreciate all the work that you've been doing, the change in tone, the transparency. It's notable, and the work that you're undertaking is difficult and far-reaching and impacts many people. And it's in the spirit of collaboration that you were talking about that I want to ask a few questions. So in your budget, you report a 7.5% growth in expense over the FY26 budget, and that's a 2.6% increase over the projections. Could you explain how much of that variance that you're asking the board to accept into the 27 base going forward? Are you expecting that full amount? I think it's around 170 million. Are you expecting all of that to stay in the budget as we carry forward?
Rick, do you want to start with that? Yeah, thank you.
Member Walsh, so I'll try to provide the beginnings of an answer for that. But I think at the hearings on Wednesday, they'll be able to provide a lot more detail in terms of that expense growth. What I will say is, in terms of our budget process, we don't assume everything that we're currently incurring for costs moves into next year's budget. Actually, quite the opposite, because a lot of the cost reduction initiatives are actually reducing kind of current expenses that are in our 26 base. In terms of the growth as well, I think what you'll hear from Judy and the other CFOs when they present on Wednesday is, a significant portion of that too is attributed to our outpatient pharmacy operation, which I think there were some questions earlier on during the staff presentations on whether or not pharmacy costs are included in these comparisons. But I'll just say that no, that's not an automatic assumption that whatever we incur in 26 flows into 27.
The only thing I'll add, Member Walsh, is, and I'm at the edge of my knowledge here, but a significant part of it is outpatient pharmacy. And another pretty significant chunk is fixed and not negotiable. It's contracts, it's other things that are built and locked in to what we're going to have to spend. So wage increases for staff are built into the budget and carry through.
Yeah, I appreciate that. And it help us as we're reviewing the budget and we see that amount of variance. It'd help if you could help us distinguish between what's structural, what's temporary, what might reverse. And with pharmacy, that's also a revenue generator. So the cost and the revenue helping us see through that transparently would be helpful.
Thank you.
Yeah. And I get the one last part as I'm looking at my notes. Identifying areas as where you do have choice. Some of it sounds like it's structural. There's not much that can happen to it, but any place where there are opportunities and choices, that would also be helpful to know. My next set of questions are about savings generated from the economies of scale. As I look back through, going back through 2024, there was the Path Forward work stream, and the number that I saw was 32 million in shared service efficiencies, and then 20 million in non-clinical expenses cut, and 130 open positions not filled. We've seen $350 million in improvement by FY28 presented today, and 270 million in expense reduction, and 125 million in additional reduction. Another number featured prominently as I look back through is 184 million over fiscal year 23 to 25. And all of those are impressive amounts. And what's difficult, the way that it's presented and the way that I'm looking through it now is to see where that actually has reduced operating expense growth, because the operating expense growth continues to go over budget and continues to grow every year, despite those large numbers swirling through the information. I don't think you could do it right now, but I'd like you to walk us through how those reductions actually lead to reduced operating expenses and where we could see that in the budget. Because, of course, the place that we ultimately want to get to is, where would Vermonters feel it? Where is it going to reduce the prices and, in turn, the premiums that they pay? So just helping pull on that string with a little bit more clarity would be helpful. And I guess, oh, sorry, go ahead.
I think one of the things that we can do, Member Walsh, to help with that is to also show, I think some of that, that cost cutting can get lost when it gets buried in how much inflation has been incurred over from year to year. So as Steve was describing, salary increases, inflation on supplies, that sort of thing, that 180 million, the 125 million that actually was reduced gets lost over time because of the impact of inflation over time. So I think what we can do is to highlight that for you as well. And I think that'll help to put some of those numbers that you've seen in the past into hopefully a better perspective.
Yeah, again, I appreciate that, Rick. And as we're thinking about working together going forward, just helping all of us see that it is hard work. There are the RIFs or the other changes. Those are difficult. They're painful. And so there must be things happening and helping us see where that's paying off would be great. Yeah, so looking at, is there a single number that is a reduced net recurring expense that's not prior savings, not revenue improvement, not avoided growth, or a future opportunity, but an actual savings.
Okay, we'll work on that.
Thanks. Similarly, trying to identify savings at affiliates in the network. The direct shared service salaries at the affiliates continue to rise while the FTEs are falling. And I'm trying to understand how that is all working together. How savings at, and if are savings, paper savings at affiliates actual savings, or is the work just shifted from the affiliate to the home office? So so that not much actually changes across the health network as far as costs. Am I explaining that okay? I'm looking for evidence of actual savings from the network. Sometimes we see decreases at an affiliate, but then a similar increase at the network, so that the savings are hard to identify.
Yeah, we could definitely help to make that more clear, because we have been supplying the transfers that we make into shared services. I think that's where you're getting at, Member Walsh. Like if a cost moved from the hospital into administrative shared services, it's not a true reduction for that hospital because it just moved from one bucket to the other. And so we can definitely break that down. I think the staff, I believe we've been providing the staff with those transfers that we've been making into shared services, so we can create an exhibit for you so that you can see that more clearly.
It's and can an affiliate modify or reject or change one of those transfers, or is the decision making all held at the network level?
So we have quite a number of positions now that have shared leadership. So we have positions where they have connection to their local leader, CNO, president of the hospital, and so on. So I would say that the local hospitals have significant say in how we're doing it, but in the efforts of efficiency and to make sure that we have the right number of people in shared services, it is consolidated essentially. And over time at the system level, you're seeing the percentage we're spending on shared services go down as a system number. Rick laid it out pretty clearly in that presentation. And ultimately, the local hospitals pay a percentage of the total shared service expense. So I do think there's a path we can show you to show that we are driving efficiency there. It's critically important for our future to have that work as efficiently as possible. And we have weekly leadership meetings where the local presidents are at the meetings, and we discuss how we would adjust things. What Porter needs for quality or for safety or in IT is regularly shared at the highest levels to make sure they're getting what they need within the constraints that we have. I hope that answers your question.
It helps. Can an affiliate make a choice without the network's approval?
On shared services, it would need to be matrixed. So I'm making this up. I don't think Porter would hire a quality leader without connecting with the system level quality leader, understanding how it fits into the total perspective. Because if they did it the way it's covered in shared services now, that expense would get spread across all the hospitals in UVM Health. So you're asking maybe a different question. Could they just on their own books put their own leader on? We're not really allowing that right now. We're trying hard to make sure we have the right services everywhere to standardize it as well.
Yeah, and can the network then override an affiliate board, say, no, we're taking this away, we're moving it to the network as opposed to keeping it local?
So to remind you, we gave significant powers back to the local boards in January of 26. Every board or every hospital presentation you see from UVM Health on the Vermont side, the local boards voted on those budgets. We gave them back some of their significant powers. But ultimately, the network board does have final authority on decision making. So the network board does carry ultimate authority, but we have given significant power back.
I appreciate that.
One last comment on that. I'm sorry, I should have added. We also, have put the local board chair now sits on the network board. So if we were overriding something that CVMC did, their board chair is there in the meeting to present their case, to make so that is also a change that happened in January 26th. And I'm sorry to interrupt you. I just wanted to make sure you knew that that was another change we made.
No, I appreciate that, and I remember it actually, as you talked about it. At the network level, could you describe for me what affordability measures or even a measure is monitored at the network level?
So probably go ahead, Rick. He's going to give you a better answer. Go ahead.
So one of the measures we've been tracking the last few years is the commercial percentage of Medicare. Now, granted, this is our internal calculation that it's high level, it's commercial revenue per 1% divided by the Medicare revenue. So it's commercial revenue compared to our actual Medicare revenue. So it doesn't line up with some of the other necessarily with some of the other comparisons that you might see out there that, for example, line up commercial revenue with kind of base Medicare revenue. What we do internally is we're measuring that to the actual Medicare revenue that we've collected. So that's part of our monthly reporting package internally that we're tracking that every month to see the progress that we're making in that area across all our hospitals.
So
I also know we're tracking inpatient cost per patient day, so we fully understand what the cost of a day is, and doing everything in our power to bring that down when we can. So that is travelers, premium pay, how you're staffing the floors, et cetera, is all tracked carefully. And I know each of the CFOs from the local hospitals can talk to that in depth.
Great. With the commercial percent of Medicare, the version that you're using, do you have an objective for 2027? Is there a point that you could let us know that you're trying to get to?
Now that you asked that question, I don't think we actually did the calculation for the 27 budget yet. But for the 26 budget, I'm just recalling these off the top of my head. I think the UVM Medical Center using that calculation was around 235%. CBMC was around 190. And then Porter Hospital was around 150 or 151.
Could you please share the 27 objectives with us?
Absolutely.
Thanks. Just give me a second. You answered a lot of my questions in the presentation. And I guess this is similar, trying to ask about a number that we could refer back to over time. Is there a measure for fiscal year 27 that the network is prepared to commit to that would show that the network's cost reductions from its shared service strategy? Could you give us something that we could agree upon together? This is an important thing, and we'll watch this over time.
So you said the administrative costs, Member Holmes? Yeah. Sorry, Member Walsh.
Yep.
Yeah, I think what we can do is I'm just trying to get to it here. A minute. So on slide 11 of our presentation, we can provide that number on a monthly, quarterly basis if you're interested. So what that number is the administrative shared service cost as a percentage of total costs, which that we have a benchmark that we are able to track for that ratio as well. That's another number that we monitor every month, and we could use that to provide that to the board.
That sounds. I appreciate that, Rick. And when you send that, if our staff has any questions or wants something quite different, I'm just hoping we work together to find something that we can monitor together and focus our conversations around.
Absolutely.
Yeah. So those are all my questions. Thank you very much. Thank you for the work you're doing. I very much appreciate it.
Thank you.
Thank you, Member Walsh. Member Holmes?
Yeah. Good afternoon, all. Again, I actually also want to, share my thoughts on the presentation today and the change of tone and the transparency. It's a huge difference, and it's really very much appreciated. Also, it's hard not to recognize all the hard work you and your organizations have been doing to, as you said, Dr. Leffler, right the ship. It's appreciated, and it's a big ship, I know, and Vermonters depend on that big ship, right, for accessibility and high quality care and all of the things. So as somebody who's seen the UVM health budgets for 12 years, remarkably, I would say this is by far the most significant, I would say, system-wide attempt to truly engage in major performance improvement, make those major governance changes that you just described, cost reduction efforts, and leadership changes that I know were really hard to do. I also want to recognize that you had to make some really hard decisions, and it meant pain caused to Vermonters and jobs lost, and that impacts families. And I know it's really hard. So I just want to appreciate that effort. A couple of questions I do have. Probably not surprising. Some of my questions are around the clinical productivity. Nobody's surprised that Jessica's asking about that. And I appreciate very much the seriousness with which you're looking at clinical productivity and increasing access and trying to reduce wait times and increase throughput and all of that. And I know that's hard, and it requires culture change and scheduling changes and a whole bunch. But you mentioned, I think, Dr. Harrington, that the clinical productivity and access improvements that are underway are likely to be greater than what's included in the fiscal year 27 budgets. So if access is going to be greater, and I can then imagine, as you described, demand for procedures and tests is going to be greater as patients access their clinicians sooner, faster, and more often. Doesn't that mean that you've likely underestimated NPR for the fiscal year 27 budgets?
So I'll let either Rick or Jen Gagnon take the NPR side of that question, but let me just use a specific example to the increasing throughput piece. In the last 2 months, our dermatology colleagues have essentially adjusted their templates to cycle their patients through on 15-minute appointments. That change went through this summer. And then in the last 2 weeks, they're also expanding the providers that weren't out there at 36 hours for clinical FTE. We see in the June financials that the increase in professional charges as seen in our WRView production popped up like 20% just in June over the average from the previous months. But when we're building the budget out, of course, we didn't anticipate that degree of increase, and we'll see if that plays forward into July and August. No signs to suggest that it shouldn't. But if you look at our budget and you look at the increase in dermatology, although we did predict a significant increase, it was really best guess, and we're ahead of that best guess just in a really tight window. As you think about, let's say, our surgical access, if we're successful in getting more patients to see our surgeons, right, and we're successful in recruiting our APP workforce to see those, to help our surgeons get to patients faster, then what I anticipate is if you have a conversion rate of, let's say, I'm making this up, every 15 patients you see in clinic, one of those needs an operation. If you increase the volume, you will drive a need for procedural access, and that procedural access, of course, drives NPR. And so for the actual NPR number answer, I don't know if Rick or Jen wants to jump in and take a shot at that.
I want to make one comment before we let the experts talk about the NPR. Member Holmes, one of the huge challenges we have right now is you're going to see for the UVM Medical Center budget, our ORs are pretty much as full as they can be. And so where those cases that get seen go, hopefully Porter, hopefully CVMC, hopefully other places in Vermont where we put some fractional specialists, we don't have a lot of capacity for increased surgical care at the medical center. And so we'll have to figure out how to manage that. And we've been talking to the medical group a lot about that. So I just want to make sure that you are aware that some of it won't translate quickly to the OR unless we can figure out places to get people in for the cases.
Yeah, although it might, as you said, it might impact CVMC or Porter's surgical cases and, imaging and other types of tests. It sounds like it might impact. So I guess I'm trying to understand the delta between what was submitted and what, given, you're now seeing in terms of increased utilization due to some of the changes you're making in clinical productivity, scheduling, access. Are the NPR assumptions in the hospitals accurate, or are they potentially underestimated, given that they didn't include some of the, the expected clinical productivity changes that you're now seeing?
Yeah, so I can speak to that on a couple of different from a couple different angles, Member Holmes. So one, I think in terms of the impact on NPR, it'll really depend on where that access improvement is occurring, whether it's in primary care or specialty clinics. It'll depend also on the payer mix. There's a lot of variables that are in that will determine whether or not the work that Ramsey has identified will impact NPR above what we have in our budget. The other thing that I'll highlight is that productivity, just focusing in on the productivity piece, that productivity improvement can come in two different forms. It can be just doing more volume, but it can also mean doing the same amount of volume with fewer clinical FTEs, if you will. So if you're doing, as Ramsey said in his opening, there may be some areas where productivity is increasing, but we have fewer people actually doing the work, particularly if we're successful at shifting some of the providers to APPs. That's going to decrease the overall cost of producing that access. So still to be determined in terms of all the variables that are at play that might impact NPR.
I think it may be helpful if we can turn on Brad's camera. Brad Cronf, he's sworn in, and this is his area of, I think, I'd say expertise inside the medical group.
Can you guys hear me? I don't have access to the camera yet.
We can hear you, Brad.
We can hear you.
Okay. Is the board comfortable if I just speak right now and we'll get the camera on when we can?
Yes, please.
Great. I would just summarize, I guess, to your point, Dr. Harrington, what you said more plainly in the question that Member Holmes asked, and to your point, not surprised. I think that's the dilemma we've been working through. And so I think that's been sort of the challenge thinking through this hearing today is really the timing. I mean, just one plain example to Ramsey's point, looking at the additional hours of scheduled time for ambulatory. We didn't know building the budget, do you assume everybody accepts those hours? Do you assume people don't accept those hours? And that's really the data we're working through right now in real time to audit and get back to you on.
Okay. Let me ask you a follow-up question around this. As you build out your budget with assumptions around NPR, that flows through to needs for commercial rate. So can you walk me through a little bit about, as you're understanding better the actual NPR that you can expect from some of these changes that you're making, how that might flow through to the need that you would have for a commercial rate? Say, for example, NPR turns out to be higher than you expected because of the increased throughput, access, procedures, tests, all of that. Would that imply less need for commercial rate?
Rick?
Yeah, if that increase access shows up in commercial volume, then that has the potential to exceed the budget that we've submitted. Again, not knowing exactly where this increased access will actually occur.
Okay. You mentioned some compensation review, looking at compensation and potentially changing it, altering it, or thinking about, how it might align to clinical productivity. And I'm wondering, do you expect the fiscal year 27 clinical compensation to include any adjustments for expectations around clinical productivity, either up or down? Meeting expectations, not meeting expectations, will compensation be impacted?
Yeah, so I'll take a first shot. Jen Gagnon can jump in behind me if I misstate anything. The compensation plan, the way that it's structured, it's built as a 3-year plan. FY27 is the second year in that 3-year plan, and the compensation pool for the compensation plan that gets distributed to the physicians is based off of the budget for FY27 for that element that has some variability to it. And so when the budgets are set, the pools are already set for FY27. If we did have increased, let's say, productivity for those areas in the medical group whose pools are driven by productivity, you would see the pool increase in FY28. That's if we don't make any changes at all to the compensation plan. And that's certainly, under discussion right now. As I mentioned, what we'd love to do is make sure that our system priorities are aligned with the way we build our compensation plan more broadly than they are right now.
Okay, thank you. And just a question around how the medical groups clinicians are billed out when they perform services at affiliate hospitals. So how does that work? What are they billed out at, say, for example, the UVMMC rate when they do provide a service at CVMC or Porter, or are they billed out at the Porter or CVMC rate? Is there clarification you can give on that?
This is Jennifer Gagnon. I'm the VP of Finance for the medical group, so I'm happy to take that question. So the professional charges are billed out based on the rates in place where the work takes place. So the medical group is the employer of the physicians, and they bill their professional charges based on where they're working at the time. There are a couple of notable exceptions to that, which are historical arrangements from very early on when the network was being formed. And that is where a couple of different professional activities, most notably radiology and pathology professional charges that take place at CVMC are billed out through UVM Medical Center. But otherwise it is a direct link to where the work takes place.
Okay. Is there any expectation that historical relationship in radiology will be changing, or can you speak to that as we go forward in the future?
Yes, and that is something that we've been just recently reviewing, and I do expect that we will be making that change in the future.
For fiscal year 27 budgets?
Not for fiscal year 27. It would likely be for fiscal year 28.
And why is that?
Really just the complexity in our systems and our contractual arrangements that we would have to work through to make that change.
I may have follow-up questions about that, but I'll leave that there for now. Let me see some other questions. Oh, I wanted to just switch to the transformation plans. And we can get into it when we get into the hospital budgets, but I actually thought it may be more appropriate for the network level. I'm wondering if implemented, the transformation plans, whether it's thinking about, more e-consults, more refer backs, a unified EHR. There's lots of work in those transformation plans that will have implications for revenues and costs at all of the hospitals. And I'm wondering how likely you think that those plans are actually going to be implemented in fiscal year 27 or even started in fiscal year 27. And then are they included in your budgets, the implications on the revenue and the cost side for those plans?
So the ones I think that have the greatest impact the cost of healthcare across Vermont, I'll just tell you, I think is the EMR is the number one, and I think it's very unlikely that will start in 27. I think a lot of work will go on to try and figure out how to do it and build the structure around it. Some of the other work that we're doing around having fractional specialists stay out at the local hospitals, I do think will help keep some more care local and lower cost settings. It'll help those small hospitals. I think there's some revenue for them there, but I think it's small. You'd have to ask them if they included that in their budgets, but I think we're in the early phases of working through that. Member homes. So I do not believe in, Rick, correct me if I'm wrong, I do not think we included specific rural health redesign dollars or programs in the 27 budgets we submitted for the 3 Vermont hospitals, because when we submitted the budgets, we didn't know it would be approved. We didn't know the scope or scale, and we didn't know the timing of when the dollars would flow and when you'd actually be able to drive the changes.
No, that's correct.
Okay. Do you have a sense of the money, my understanding is the money is going to be allocated, at least for the first year, pretty soon. For the, I guess, for more of the lower hanging fruit, like not the EMR Unified, but some of the other initiatives that are in your plan that may be more likely to be implemented if the funding is available, which hopefully will be. Do you have an idea of how it might potentially impact the 3 hospitals' budgets? Have you done that modeling for fiscal year 27, for whatever would be implemented in fiscal year 27, how it might impact the budgets?
So we do have an expert on the rural health redesign dollars. I don't think she's here. But once again, at my high level of understanding of this, if the dollars got implemented, let's say in October, you'd do the work, you'd be hoping to start it in February, March, something like that. I don't think we put exact cost savings into the budgets because we were submitting these budgets before we actually knew what would be approved or not. So I don't think there's a direct tie to if this got initiated, we believe this is the savings we'd see.
Okay.
Can I just take a shot to using a specific example? So I mentioned earlier when I was speaking about the notice of intent to fund one of our telehealth projects earlier when I was giving a presentation. That's I think a $2.1 million grant to strengthen telehealth capacity across the UVM health sites in Vermont for virtual nursing and in consultation. And then expansion through our non-health system partner sites, and then establishment of telehealth access points through a partnership with Mama Val. So we did not put in our budget the ability for our stroke neurologists to have that WRVU charge capture for a consult in this case. I will say that the benefit of this service is really keeping these patients locally, stopping the expense of transfer, stopping the burden on the patient from having to be moved. And the professional revenue on the medical group side of this is really small for these consults. Even though we do a lot of them, I don't think that even in this particular case, we've got the intent to fund the award, kind of a pre-award notice that is going to translate to much in there. But the answer to your question is we didn't budget as if we were going to get this award and capture that volume in FY27.
Okay. I guess some of the other ones I was thinking about were e-consult and refer backs could potentially be keeping care, say, for example, at Porter and CVMC rather than at UVMMC and specialty clinics. And so I'm just trying to understand how all of these initiatives are all going to play out and the net impact of them on the 3 budgets. And I wondered if you had done that kind of modeling as well, but it doesn't sound like that's happened yet. So
yeah, in concept, not in putting pen to paper for the budget.
Okay. I given the time constraint, I'm just gonna, I think I'm good. I'm gonna turn it back over to you, Chair Foster. There's 3 other board members that have, I'm sure, many questions. So thank you very much. I appreciate it. And I may ask more follow-up questions when we get to individual budgets as they relate to some of these issues and other issues I didn't get to. So, but thank you. Of
course.
Great. And I'll turn to Member Teachout.
Thank you. I think I'll start with PHSO questions since we haven't really gone there yet. And I had a few. Thank you, Jessica. 2 were just so I make sure I understand your slides correctly. So could you elaborate on what you mean by PHSO non-patient revenue expansion in slide number 14?
Slide 14, Rick, I believe is one of your slides.
Whoever can answer the question.
Yeah.
So this is contracts that we have with employers that isn't patient-related revenue. I don't know if you want to expand on that, Jessica.
Sure, happy to talk that. Some of that is like our direct-to-employer work. So work that we're doing to provide essentially curated population health services to self-insured employers.
And do you do that with through insurance carriers or directly with the employer?
Directly with the employer.
Thank you. My next question, just specific to the slides, was on slide number 25. You said that in FY27, you have a priority to shift the Medicare methodology for outpatient services. Can you tell me exactly what you mean by that?
Yeah, I talked a little bit about that in my comments. What we're trying to do is really have more Medicare-like aligned methodologies with payers so that we're able to do that work I talked about with what I'll call pre-reference-based pricing work. So if we have a similar methodology and we can figure out what the percents are together, then it's easier for us to make changes. And that requires alignment with the payers and then changes on systems on both sides.
Great, thank you. So the numbers that you gave in your presentation, some were the quality things and other stuff. Were they across the entire network system and including the New York hospitals?
So we provided network numbers, yes.
Network numbers, okay. And then is this all, because you talked about it being with primary care physicians, is it only primary care physicians that are part of the network?
So when we think about managing panels and managing patients, we think about those that are attributed to primary care. And so we think, so that's all 31 of our primary care sites, both family medicine and internal medicine across our entire system. So that's the attributed membership for primary care.
Okay.
And then also those direct to employer contracts as well.
So as part of this, do you attribute how much is for your services for Vermont patients, and do you share the cost of the PHSO back with the local hospitals for your services at those hospitals, or is it by who the commercial insurer is of that patient, or the Medicare or are you attributing the patient by state and then the costs of the PHSO by state?
So let me just make sure I understand the question, and then I think I can answer. I think it's answer both parts of it. So the first piece is the attributed lives are attributed to primary care panels, and those are the panels that are being managed. And we do track all those numbers by practice. So by state, by practice. In terms of how is the population health services organization budgeted and treated from a budget perspective, and Rick, feel free to jump in here. It's like other shared services in terms of the way that it's charged out across the organization.
And I believe that's by revenue, correct, of the hospital? So
Correct,
could there be a mismatch between how the shared services for the PHSO is being offered versus how you're billing the hospitals for that service?
So in any of these shared services, whether it's HR, IT, or population health services, whether or not total revenue is a perfect alignment with how the partners are actually utilizing those expenses, a case can be made for pretty much any of those. But to be clear, yeah, the PHSO is based on total revenue. And the reason why that question on non-patient revenue kind of threw me for a minute back on my slide is because anything that we bring in for non-patient revenue into the PHSO actually reduces the total cost that we then have to allocate out to the partner sites, but it is allocated out just like HR and IT based on total revenue.
Okay, thank you. And then how do you distinguish improvements, quality improvements, like what you were showing to us on the slides, that are attributable only to the PHSO versus the work that was done by One Care Vermont last year, or the Blueprint, or payers' own care coordination programs?
That's a great question. So the Blueprint is integrated into the PHSO services. So the Blueprint team is integrated into that work. In some cases, there are certainly joint efforts that are happening, but what we try to do is map back directly from the work that we're doing to understand what the impact was for a particular patient or service. So we're really managing at that patient level when we're doing panel management to see what the impact is. And the example I gave in depression screening and follow-up was a really good one, because we looked at how we were performing. We then peeled the layers of that onion back with the primary care teams to understand what that was. Now, could a payer also have an impact, or could an additional program have had an impact? Potentially, but we may have known that by looking at the individual patients that weren't getting screened and understanding where that screening was occurring or where it wasn't in order to make sure we're putting it in place.
Okay, great. Thank you. And I think my last question on this topic is, do you calculate a return on investment for the PHSO?
We do. We're margin positive for the in the FY27 budget. The PHSO is margin positive for UVM Health.
Is that in the materials and I just missed it?
Rick, we can clarify as needed.
Okay.
And happy to go back and look at what's been provided in details and make sure that it's spelled out clearly for you.
Okay, thank you. Really appreciate that. My next questions are on the pharmacy, and I guess I'll overlap with the PHSO. Does the PHSO look at the pharmacy for the patients in your panels and try to help patients either access lower cost pharmaceuticals or address their health needs without using pharmacy?
At a high level, I will say yes. So when the PHSO uses data to understand what the total cost of care or spend is, we're looking at that at the population level. And then down when you look at high cost patients or high cost members, I think that is partially where you're going probably with the pharmacy question. Oftentimes those are pharmacy related. And if there are other options, we certainly have care teams that are looking at what those options are in conjunction with providers to make sure that we're making the best decisions for patients. And sometimes those financial decisions vary depending on the payer that the patient might have. And so there's opportunities. Sometimes there's opportunities direct with pharmacy programs. So certainly helping patients navigate their pharmaceutical costs is a part of what's done by PHSO teams.
Okay, so just to put a point on it, you are identifying high cost patients by also including their pharmaceutical expenses.
At high level, I'll say yes, when the data is available. So, sometimes we don't always have full encompassing data, and we certainly don't have all payer, all claims, all pharmacy data on every single patient, but where available, we're using the full picture to be able to help make decisions for patients and help manage their care.
Great. You would have data available if they purchase their medications through either the UVM retail pharmacy or received it in a hospital-based setting at one of your facilities, correct?
Or if we were in an arrangement that included a full claim set.
Okay. Okay. Thank you. Okay, so now I really am going to get more into the pharmacy. I did notice when I was looking at the numbers that you provided us in the spreadsheets, this is probably for Rick, but whomever is the appropriate person. In FY26, the budgeted numbers you gave us for 340B retail pharmacy growth was, or retail pharmacy revenue is 34.6 million. And now you're projecting to end the same year at 60 million. Why is that number so different?
So I think member teacher, that might be the UVM medical center number that you're referencing there. I believe it might be. So I think I don't know if Judy is on today, but we can certainly get her to answer that question on Wednesday during the hearing.
Okay, heads up, that's coming. Does the hospital have provider prescribing policies for medications? Like, do you have a pharmacy and therapeutics committee that makes recommendations about drugs specific to your facilities?
We do.
Okay. And does it do it across all the network?
It does now, yes.
Okay. And does it make formulary or other sort of prescribing policy recommendations?
So I have to admit, I haven't gone to it in quite a while, but I believe it does, right, Ramsey?
Yeah, Rick, maybe using the example of the biosimilar. Can you speak to that, Rick?
Yeah, the P&T committee is looking, in addition to just the efficacy of the drugs before they're introduced, they're looking for the lowest cost alternatives. That's part of their charge and what their constantly looking for. And when you look at our margin improvement efforts, our cost reductions, there is a line actually on there for the system formulary opportunities. And so they're constantly looking for and actually finding lower cost alternatives. The VP, Wes McMillan, actually just sent me a note at the end of last week that was about 800,000 that they found by using a lower cost alternative just recently. So that's part of what they do and part of their charge.
Thank you. So just to clarify, lower cost for whom? Lower cost for the hospital to acquire, lower cost for the patient to purchase, lower cost for the commercial payer. What are you thinking about?
Yeah, so it starts with lower cost for the hospital, which then obviously allows us to translate that into lower cost for patients.
And does that include the 340B acquisition cost?
So I think this question I think may be better answered by kind of the expert in the space. I can tell I'm starting to kind of run out of rope here. So if you can, we can certainly take up that question and follow up.
Sure, happy to do that. And then when you're considering affordability for patients, do you consider the 340B and hospital administered drug impact on premiums in the commercial market?
So you want to try, Rick? And then yeah. So, I mean, at the highest level, the way I think about this member teach out is we figure out the total expenses it's going to cost for 27 for the care we hope to deliver each of our local hospitals. And we figure out what the 340B discounts are, and all that goes into what we ask for commercial insurance. It's all rolled up into one big number. So what I would say is anywhere we generate savings, anywhere that we do better overall should have an impact on what our commercial rate ask is.
Okay.
And if you need more detail than that, we'll have to get to the experts.
I think I'll save some of my questions for the UVM Health budget. So then I saw the bottom line numbers that you presented for the New York State hospitals. Why are you not repaying Vermont back proactively with the positive results at some of the New York hospitals?
Yeah, so the positive results are still, while it's great improvement, great work, it's still not enough to reduce that balance. The fact that we were just able to keep it from growing this year is an accomplishment and is reflected in those improvements. When you look at those margins, those small amounts that you see there reflected in that chart, you have to keep in mind that they too have capital expenditures that need to come out of their operating margin. So by the time you generate a margin and you pay for the capital improvements that you need to pay for at your facility, there's very little left over to start to actually make an impact with decreasing the balance. And I'll be honest, internally, that's certainly not been our focus. Our focus has been on improving the sustainability of those New York hospitals and keeping the balance from growing this year and next.
Okay, thanks. And then the last questions are a little bit follow up on what Member Holmes was asking you about some of the transformation plans. You had expanding ultrasound into primary care. You had expanding e-consults. And my questions were, are you, for these things, are you seeing a need, especially with the ultrasound and primary care, that you're trying to address with that?
Yeah, I'll take a shot at that one. Yeah. So in the evolution of clinical practice, the ability to make bedside, diagnoses or to guide diagnosis and treatment has been dramatically increased as ultrasound technology specifically has become available. It also makes things safer. So for a primary care clinic that has a doc that can adequately use an ultrasound probe, that patient that comes in a little short of breath, they can put the probe on their chest and see, you know, whether there's fluid from congestive heart failure, or if there's not, they can see if there's an effusion. For the patient that may need an abscess drained, they can see exactly where the abscess is, and they can watch the watch the needle, or they can see that it's actually not an abscess, you know, that there's just an infection there that needs antibiotics. And so it's more about keeping the patient in their primary medical home to get as much of the diagnostic and treatment options that we can give them in that home without having to ship them over for an x-ray or to send them out for a lab test or something else that we would do without that capability.
Okay, it also would presumably speed up the access to care because they don't have to wait for another appointment. Specific to the e-consults, my question was, are these asynchronous visits or are they telehealth visits? How exactly are the e-consults working?
Brad, do you want to hit that one? Yeah.
Yeah, the e-consult is effectively a primary care clinician asking a specialist a question. And so the idea here really is a decision tree. So if the primary care provider thinks that they can get a question answered and to avoid a visit, they can do that through the electronic health record. I know in some of the language we submitted, I think it was through maybe a clarification in one of the RFIs, there was a question about the challenge of the interoperability. And that comment is really linked to our organization kind of having fits and starts, working with partners outside of the organization, where there's a lot of interest to do this, but absent a common EHR, there's duplicative documentation, there's extra steps on each side for the clinician, that sort of thing.
So this is clinician to clinician. Is there any billing of the patient for these services, or it's just purely avoiding a visit?
The electronic consult so when the specialist performs the electronic consult, sends the note back to the primary care clinician, yes, there is a bill that's dropped. And so that generates much less work RVUs than a visit. It's a much smaller charge than a visit, yes.
It's a smaller charge. I'm just curious because I thought that there was legislation that allowed it to be billed the same as an in-office visit.
That's my ignorance then. I was of the impression it was a smaller charge.
I thought that was for telehealth. I thought that was for actual telehealth visits. I'm not sure it includes e-consults, which are asynchronous. We'll have to look at that, Member Chicho.
That'd be great if you could just get back to me. I thought it was both telehealth and asynchronous visits, but I could be wrong too. So I think that those were the end of my questions. So thank you for your time. I really appreciate it.
Thank you. And Member Merman?
Hi. Thanks for everybody's endurance today. I know we've had long hearings in the past, and this one doesn't seem quite as long, but I was reflecting on that and looking through the budget and realizing that the medical group as a standalone, the shared services as a standalone are each, I think, bigger than the next largest hospital in Vermont. So I do think it's definitely worth taking the time to think through this, and I appreciate you all doing it with us. And I think part of my, as a board member, struggle with today is trying to figure out what's really like network versus individual hospital. And so I think others as well. So if it seems like my questions are more appropriate for individual hospitals, go ahead and just defer me that way. I want to start similarly to the comments of several of my colleagues, just really appreciating the shift in tone and substance from the prior submissions. I have not been here the 12 years of Jess, but I think this is my Well, I think I'll be here as my third, as I can't, it seems to blur together, but I've read back probably to 2018 for budget submissions over the years, maybe 2017 at times. And I do think the tone of this submission and the substance of this submission is quite different, and it's very appreciated. Owen mentioned the words humility, which is actually I'd written down in my notes prior to that, willingness to share your struggles, your challenges with this moment in leadership, which I think is a uniquely challenging one. And I think there's a lot to think about of how we got to where we are, but I think forward looking and where we're going is really important. And I think that I imagine in all of your positions, trying to communicate with the people who you lead every day, the why of what we're doing and why you're doing these big changes has to be a massive challenge. And I think I appreciate from your comments today and the written submission, I think an understanding of the why. And I think that really does matter, is that costs have gotten to the point where they're not affordable for Vermonters. As Kirk mentioned earlier, every 1% in commercial price increases, it's broad data, results in job losses or economic stagnation or other challenges for communities. And so while you're trying to lower costs, and I think Steve, you mentioned that there clearly are job losses, and this impacts people. On the flip side of that, and that's those individuals, I think we all feel for them, and I assume most of us know some of those people and their friends or colleagues throughout the state. And many of them, I think, had very important roles in your organization. But on the flip side, at the macro level, hopefully this will lead to other economic gains for Vermont and our communities, and economic security for our community. So I just want to set that off at the beginning. There was one sentence in the narrative that sort of reminded me of sort of the older approach to the budget, which I just wanted to sort of address, but I also think you today have all addressed it as well. But there's a quote that says, Vermont hospital commercial rate requests have been historically based on hospital cost pressure on projected per unit inflation offset by expected Medicare and Medicaid revenue, and basically not to cover New York. And I think that may have been the case, that it was purely on cost pressure, but what is really clear today is the focus on expense pressures and reduction of expenses, and to achieve margin through expense reduction. And I think everybody's comments today relate to that. And I think the importance of that is sort of the fundamental thing here. And expense reductions through operational improvements, I think Ramsey got to a large degree of that, is, you have expense reductions, and now you're going to probably have revenue growth with these associated expense reductions. So here I am talking, I should ask you questions, but many of them have been answered through your presentation and my colleagues' questions. So let me see if I can get to what's left. So I think this is largely for Ramsey. I wanted to just look a little bit at some questions about the Alvarez report with regards to the medical group losses. I don't really want to pull up a bunch of slides because I think these are kind of rough numbers anyways. But when I was looking at the UVM revenue worksheets, when I look at outpatient physician revenue and add it up for 27 budget, I got about $364 million. I don't think that includes inpatient. I don't think that includes other grant sources and whatnot. And I look at the total physician fees, salaries, and benefits, I get about $12 million less than that, which I assume includes all the non-clinical FTE. So with that, what I'm trying to understand is that is a positive margin, and that's not including a lot of the revenue sources on that group. What else is driving the medical group losses that are so profound? What else is in the medical group expense line that's not that's not reflected there.
Jen, can you take a shot at that one for me, or Rick? Yeah.
Sure, I'll start, and Ramsey, you can add. So in the medical group budget, as you noted, Member Merman, is the professional revenue only. It doesn't include the outpatient or inpatient revenue. And then in the expenses, it's all of the salary and benefits for our physicians, our advanced practice professionals, all of the support staff that sit inside of our ambulatory clinics and support the operations of the clinics, and then all of the operating expenses like pharmaceuticals and med surg supplies and that sort of thing. By far, the largest expense in the medical group is the salary and benefits of the physicians, the APPs, and then the support staff.
So it's only the outpatient physician revenue that gets attributed to the medical group? You said there's no inpatient professional revenue that gets attributed to the medical group?
It's only the professional revenue. It's not that
Okay.
revenue that's captured for outpatient procedures or inpatient activity, only the professional component of that work.
And so I think it was, remind me the number for UVM. I can't remember network-wide versus UVM, because I was giving UVM revenue numbers and expense numbers was something like $125 million loss. So all of the other components of that are, of the non-physician revenue and salary expenses adds up to something like, 125 million or something.
And I just opened the UVMMC P&L, and the budgeted loss of the medical group at UVMMC alone is 167 million for FY27. The patient revenue is 383 million at UVMMC, and so the delta is all of the expenses that I mentioned. So again, staff and APPs do make up quite a bit of expenses in the group.
I might have missed it in the budget submission. There's a lot of documents and spreadsheets and whatnot, but is there a way to see the medical group broken down by expenses and revenue, to try to understand, say, drug costs as the driver of loss in the medical? You're saying that medications get, if it's a physician administered medication, does the expense go into the medical group?
If it's part of the ambulatory clinic activity, yes. So if it's a drug used in the ambulatory clinic setting.
Yeah, I think some more granularity that would be helpful there. There is one of our worksheets is the operating expense worksheet. And I was looking again at UVM, and there was a large increase in total all other operating expenses from what would be, I think it was 26 budget to 27 budget, or 26 projected, 27 budget, from about 10.8 million to 48 million. So this area of $37 million in growth, and these all other operating expenses within the medical group. It sound like you're trying to reduce actually that's medical group administration. So that's, I don't know, maybe I think I sent some questions in through the staff, and maybe I can get further answers on these, because I think it's a huge line item, this medical group. And so I think trying to understand it better would be helpful for us.
Sure, we can certainly break it down at any level of detail that would be helpful if you don't have the materials from the staff.
Okay. I guess one other area I'd like to talk about is the productivity data. I think, gosh, there's so many different ways to go at productivity. And I think maybe, Steve, I just want to ask a question of you, because I think this goes back to a conversation that I feel like I had with you years ago about productivity when you were the Chief Population Health Quality Officer, and we were talking about at some forum, it wasn't a personal conversation, you might have been speaking, but about RVUs. as a measure of clinical productivity with the population health hat on as sort of a challenging measure because you're really measuring billing as opposed to productivity. And I was just wondering how you think about that within regards to your medical operations now.
It's such a good question. So what I would say is when Vermont was moving towards value-based care, whether it was the AHEAD model, one care, whatever, pure RVUs is probably not the best way to measure people. You want to figure out, are people doing things to make people healthier and overall need to require less inpatient care? And I would say in that world, an RVU, pure RVU model is not really what you want to measure people on. And I will tell you, in many ways, I think the medical group responded to that and started shifting the contracts they built to be more focused around delivering care to get people healthier. The truth is, as Vermont's moving back towards a reference-based pricing system, which is really price control and not really utilization control, honestly, productivity becomes more important in how you do things. And so I finished my comments to today as I still believe value-based care is the way forward. I believe how we're going to keep Vermont or help Vermont be more affordable is have more Vermonters be healthy, which is why Jessica's presentation to you is so critically important. The work in those primary care offices to keep people healthier. But I believe the contracts that we have for our doctors going forward are going to need to have some balance to make sure that we are hitting key performance metrics, key quality metrics, key engagement metrics, and some productivity in there while we live in this kind of dual world, Member Merman, around are we in value-based care as a state and what does that look like? So I think you'll see us move back to having some more clear productivity measures across the medical group as Vermont shifts as a state into what it's looking for.
Kind of where I thought you were going to go with that. It seems like it's one of the challenges of RVUs, but I wanted to bring up the discussion publicly, so I appreciate it. Member Holmes, I think, started this, I hope you're not offended by the word crusade and trying to understand productivity and I think the first round that we got of productivity from UVM was in patients per clinical FTE. And I remember the hearing because I think it was clear that we both took the spreadsheet and added columns to try to figure out, like, how does that break down to patients per day? And I think she presented it, and I was like, I have that same data right here. And it sounded like that was not particularly reliable data. And then I believe the recommendation was to move to RVUs. And then I think there's also been some discussion about, well, this isn't the most reliable data. And I've spent some time looking through the productivity numbers from UVM for the last couple of years and from this year. And I think that there's challenges in that data in trying to understand productivity. I think one example would be for your anesthesia group. You have your anesthesiologists at a pretty high productivity level at UVM, where your CRNAs are like near the bottom. And I assume that's because the anesthesiologists probably end up getting most of the RVUs from that encounter. I can't imagine your 32 CRNAs are sitting around the less than 10th percentile for productivity. So I guess my question for you all is, I think a challenge for UVM over the years has been data, operational clinical data. And what's the data strategy moving forward? I understand there's changes at the DMO and that structure. How are you going to ensure that UVM has the data needed to make the operational improvements that are needed to be financially sustainable and be the anchor of our healthcare system?
In the first week that I became interim CEO, way back in October, which seems about 5 years ago now, many days, one of the first things that I asked of our team or said is we need to have better data. I was in a meeting in that first week and we were trying to make a big decision and we did not have data that was actionable, that we all even agreed what the measures were. We've done a huge amount of work on data. Now there's good data on emergency care. We've had a lot of new measures around our quality dashboards. We've standardized them across the system. We have a monthly financial dashboard now. And all of those dashboards are fully transparent to every single person who works at UVM. So we're not trying to hide anything. We cannot make good decisions going forward without a clear understanding of what we're measuring, how we're measuring it, what the measurement means. And so we brought in some outside support to help. It's so critically important for us. to build out our system. And ultimately, when they've got it in a better spot, we'll resume doing it all internally. But we did bring in some consulting help, which I think has been a very good investment, honestly, for the improvements. I can tell you that I've been here 33 years and I've seen more improvement in our data in terms of how we use it and how reliable it is over the last 6 months. So I do want to say that. And one other comment, I just want to go back to your previous thing about, how we measure productivity. I'm sure what Ramsey says to me all the time, which actually makes sense, is what we really want to do is get people access when they need it. We want to get people seen in a timely fashion. The ultimate productivity measure is to have the right number of clinicians that can get people in a timely fashion that we agree with, that we can afford, right? I mean, it's some measure of that. And exactly how we do that, if we can get people seen at a rate that Vermonters can afford, I think we'll be there. And at least what I hear from the medical group is trying to do that, get more people seen within the expenses reductions that we're trying to do. But I hope I answered your first question. Data is critically important, and we are working very hard and making investments right now to have good data systems.
I'll add one thing to that, Steve. You didn't mention that when we just sat down with our capital budget for FY27, we were going to have to make some really hard decisions. And in the end, the capital that's at the CO discretion, Steve elected to drop that on the recommendations coming to improve our enterprise data warehouse and the investments that we need to make so that we can put all these pieces together to improve reliability and accessibility of the data across all the different parts of the system. Jessica can probably add to that if I misspoke there.
I'm happy to provide more detail as requested. I think both you, Ramsey, and Steve have summarized it well. If there's more data specific questions, I'm happy to take them.
I don't know. There's endless questions, but not for this forum. And I think I can maybe follow up with something in writing, but I don't know if it's relevant right now. Just a few other things. Ramsey, you're talking about the comp plan and have the system priorities line up with the comp plan. What I think I'm hearing everyone say today, but I just want to speak out loud, is to make sure that the community priorities drive the system priorities that drive the comp plan. So those are all in alignment. And I think that was communicated, but but I just wanted to sort of say that out loud in this forum to encourage it. The only other thing, there's two other quick things that I have, which are, you talk about health plan utilization and cost decreases in one of those tables in there of all the various things of $25 million over the next 3 years. And I'm curious, is that your employee health plan? And how do you aim with, I think previous budgets, there's been discussion of increased employee healthcare expenditures. Everyone else in the state has been talking about increased employee healthcare expenditures. How are you going to decrease your employee healthcare expenditures by $25 million over the next couple of years?
Go ahead, Jessica.
Rick, you came off mute. So I'd love to say it's all going to be population health management of our population. And we will be a critical part of it. And the work that we're doing in our direct to employer on our own employees is a part of it. But Rick, why don't you talk overall? And I'm happy to fill in.
Is that one of the contracts?
That's one of the contracts, correct? Yes. Rick, why don't you talk overall? And I'm happy to add commentary where needed.
Yeah, I mean, I do think that what Jessica's team is doing is going to have a significant impact on that, on our achievement of that target over the next few years. What's embedded in that is also part of what member Teach Out asked about pharmaceuticals. So we look at pharmaceutical costs as well in terms of our own employee health plan to try to reach that target. You likely heard we had to make the difficult decision to eliminate some coverage about a month ago related to GLP-1s. So it's those types of things that we're anticipating we need to continue to do to reduce our health plan costs and get to that $25 million number. I mean, our health plan cost is a big number, and in relation, that 25 million is we feel is certainly achievable.
And then in terms of what Rick referred to for the direct to employer work, we're providing what I call curated population health services to the population. So that's separate from and inclusive of those who have UVM health PCPs, but also those who do not. So we make sure that everybody is connected to primary care. The teams, and their care management teams, their care navigation teams are available to assist with questions and connect people to services. They make active phone calls to every single member who goes to urgent care or the emergency department and make sure that they're connected to follow-up care, whether that be, again, within our health system or outside, because there are those who get their care outside. So that's where we're really looking at, again, detailed navigation services for the entire organization. We also do deep dives in data and analytics and are providing regular reports internally. So that helps understand from a population health perspective, what do our members need? And I have to say the feedback that we get is incredible. People feel really connected and they feel seen, especially when sometimes their families are navigating complex illnesses.
One of the slides mentioned the right place and the lowest cost setting for trying to direct patients for services. And I think one of sort of the recent mantras within health expense growth is that moving things out of the hospital is the way to do it, is to control healthcare expenditures, because if you move things out of hospital-based services, you avoid facility fees and higher market leverage and higher prices. Does your population health management system send patients to non-UVM providers for things like, say, imaging or surgeries that can often be far lower expense?
Yes.
And how
The
does
short
that,
answer is
how does
yes.
that
The
work?
long,
Yeah.
So how does that
Yeah.
work? So a lot of that is patient choice and conversations that our care team might have with the patient about the type of care that they need and what their options are, and then fully understanding the benefit. So the team is providing a curated service based on understanding what that patient's benefits look like, and then having a conversation with the patient. That assumes, of course, non-emergent care, but someone who's making decisions and understanding what all of those decisions might be. So yes, looking at what all the choices a patient might have.
Great. Well, thanks. I think I'm going to save most of my rest of the questions for Wednesday, and I appreciate you guys coming today and having this conversation.
Okay, we did pretty well on time. Why don't we take a quick 5-minute break, and then we'll turn to the liaison team updates. We'll come back at 2:38 and we'll hear from Mr. Smith and his team. Thank you.
You're off the record at 2:33 p.m.
All right, Mr. Smith, are you here?
Yes, I am.
Great.
Can you hear me?
Can, although I can't see you, which always concerns me.
Yeah, let me try here, see what's going on.
There we go. I don't like seals sneaking around in the cover of darkness. That made me very unnerved very quickly.
Well,
okay, great. Do you have everyone with you, Mike, that you need? I see Nancy
yeah,
coming on.
Nancy is the Stephen Gorman's on vacation.
Okay, great. All right, Miss Mulligan, we can go back up the record.
I'm looking for my backup recording. I don't see it. There should be a number that's called in 480. Yeah, I don't see it in there.
Okay. You need a minute, or is there something we can do on our end to
Oh
help?
no, I'm in the way. I'm in there. It shows that I'm in there. I just don't see me up. You don't see me? You don't see the number?
There's 135.
I know it's hard to look through them all. But that's what I've been trying to do, and I don't see my backup number in there. Would it be easier if I hang up and call back in so it's the freshest?
Sorry, give me the area code again.
480.
Yeah, maybe dial back in just in case.
Okay. Okay, give me just a second then, and I'll do that right now.
Sure.
Do you see me that time?
Don't let me try and refresh on my end. I don't, but I mean, these are recorded publicly, so there is kind of already a backup. So if you're comfortable with, your presence and then also having another backup, I can proceed. But if you want another minute, that's fine too.
If y'all need to go ahead and proceed, I'll try again, but I'll do it behind the scenes. So we can go ahead, but I'll try to call back in, but we can go ahead and go online. It's my second backup. I have 3 backups.
Okay.
So
All right.
we can go ahead.
I'm confident then. All right.
Okay.
We'll go back on the record. So we'll resume the Green Mountain Care Board's hearing of August 3rd. We have 2 members of the UVM Health Liaison Team, Mr. Mike Smith and Ms. Nancy Kane. They're going to provide an overview for us. Before I turn it to you, I did want to thank you both and Mr. Gorman for your significant efforts with a lot of substance, a lot of value that you've delivered to the Care Board, to UVM, and to the state of Vermont. I've read your memos with intrigue, and they have been really phenomenally well done and had a lot of depth. I greatly appreciated the last memo and the insights and suggestions as to the Care Board. A number of things I agreed with wholeheartedly, and some things that we need to look at internally in our role of improvement, and also the comments on Blue Cross and UVM. I was recently asked by media, what are the things I did well as chair and what are the things I did poorly? And hiring the liaison team and bringing you all in was one of the things I believe that I did really well, which as any great leader does, I really was taking credit for Member Holmes's idea. So with that, I will turn it to you, Ms. Kane and Mr. Smith.
Well, thank you. I'll start off and then ask Nancy if she wants to add anything. Chairman Foster, thank you for the opportunity to present our memorandum to the board today. This is the liaison's team fifth memorandum. This one is on the 2027 budget submission from UVM Health. As we mentioned, Nancy is here, but Stephen is on a well-deserved vacation. And as we mentioned in the memo, we are critical in some budget areas, but I do want to start off this by saying we wish to impress that overall progress has been made since our last year 2026 budget memorandum, which somebody had reread and sent me an email the other day saying it was pretty hard hitting, and it was meant to be pretty hard hitting. So much progress has been made since 2026. And I just want to also say that under its new leadership, UVM Health has demonstrated a commitment to improving its operations and reducing its cost. And for us, that is a welcome change. We really appreciate it. We appreciate the leadership of Dr. Stephen Leffler and his team. In addition, I just want to let the Green Mountain Care Board know that this is our last budget memo for the liaison team. The liaison team will wrap things up September 30th and have scheduled one more memo that will sort of wrap sort of our engagement up. In essence, I've fired myself on September 30th. So, but I also think UVM is in a place, as you recognize, a very different place than it was 16 months ago. And Nancy and I and Stephen is still available. But we felt that this was a good time to sort of let the process move on with UVM without the liaison team. We've analyzed the 2027 UVM budget in the context of our broad focus on affordability and specific focus on the recommendations of our last memo 4 in May of 2026. And that was based on three sort of fundamental principles. Multiple metrics in healthcare that right now healthcare is unaffordable in Vermont and costs must be reduced. Second, that UVM needs to operate its medical group more efficiently. And then 3, between now and 2030, UVMH will require expenses to be reduced by at least $300 million. But one of the general themes of the memo in this 2027 budget memo is that beyond pricing and cost pressure must be sort of a shared responsibility among all parties, both regulated, non-regulated, looking at payer versus provider. Everybody needs to sort of come together to sort of tackle this issue of affordability. Although UVM is a large player in the healthcare environment, it isn't the only player. And everyone, the theme in this is everyone sort of needs to pitch in. At a high level, our findings and recommendations include the following. The liaison team believes an additional $50 million in expense must be removed from the 2027 budget that was submitted by the University of Vermont Health. UVM Health Medical Group must increase its clinical productivity in the 2027 budget. And I just heard Dr. Harrington talked about the improvements they've made. When they submitted the budget, we saw a 1.7% reduction in productivity in the budget. And so that set off our recommendation that it's got to be more than that. It can't be a reduction. It's got to be an increase in productivity in 2027. UVM must immediately implement an established and proven management system to drive cultural a culture of continued improvement and operational excellence. This is an important finding, and it is, you know, whether it's lean or some other sort of operational improvement or proven management system, we need a system at UVM that sort of tracks down and solves issues that are longstanding or just arise so that they don't become bigger than what they should be. We don't have that system now. And I think a system like that would greatly improve the operational management of UVM Health. As you mentioned, Chair Foster, we broadened out a little bit under the theme that everybody needs to be a player in this healthcare environment, that the Green Mountain Care Board must streamline the budget process and include multiple year budget approval process. And we also said that Blue Cross Blue Shield of Vermont must operate more effectively to control cost. We did recognize that UVM MC has materially reduced its net patient revenue from commercial payers in 2026 and 2027. But UVMH and UVMMC in particular, it's got to do more. They've got to reduce its expenses to correspond to the reduced revenue. And as you see, UVMMC is going to be recording a $43 million deficit as in 2027, and the network in total is going to be $14 million deficit. UVMMC is projecting, as I said, a $43 million deficit with expense growth. Both UVMMC and UVMH in general, and again, getting back to our recommendation, must reduce expenses by at least $50 million. In addition, UVMH has budgeted lower productivity, as I talked about. This impacts wait times and clinical productivity and costs. They need to do more in 2027. And we talked about the fact that the compensation has to include some element of productivity. And we recommended that they bring in a compensation consultant and look at how you change the productivity matrix within their compensation schedule. And we talked to the compensation committee about that in terms of, productivity. We didn't feel there was enough linkage to productivity in the compensation schedule. UVM will be facing challenges on multiple financial and operational fronts. The size and complexity of an organization like UVM makes it almost impossible to drive any sort of improvement without adopting a proven management system. And I talked earlier about that. We strongly recommended that they embrace lean, and other recommendations included more transparency into the UVM Medical Center and UVM School of Medicine costs and benefits, as well as exclude the cost of retail pharmacy from operating expense benchmarks. And then, of course, I mentioned that at the outset on the high level, and we went into more detail in the actual memo that Blue Cross Blue Shield of Vermont needs to do more to help control cost. One of the things we were just kind of disappointed with when we read Stephen Gorman was tasked with reading the filing was the sort of the avoidance of having any role in affordability. And that is something we think that everybody should grasp onto and be part of a main mission to bring affordable healthcare to Vermont. So just in conclusion, and there are 20 pages of memo here, but I won't go through all of it. But just in conclusion, I think UVM has made good, we as the liaison team thinks that UVM has made a good faith effort to keep commercial NPR and commercial rates within or near your guidance. However, there is more to do, a lot more to do. UVMH will need to urgently address its expenses and its productivity to ensure affordability, its sustainability, and a place where the patient enjoys a much better experience than it does now with the wait times and other experiences at UVMH. Again, although UVMH is a large healthcare system, it cannot be expected to be the sole contributor to the state's healthcare affordability crisis. And again, I can't emphasize this enough. It's going to take a village to do this. It can't fall on one person, although they are one of the biggest healthcare providers. It has to be sort of a concerted effort, especially on the unregulated side. Nancy, do you want to add anything to what I said?
Sure. I'll try to add a few comments to what you just build out what you've been talking about. I think when we talk about productivity, what we're really, the main outcome is not just more volume, but better access. And the access wait times are pretty ridiculous right now, even though I know there's been a lot to being done, but we think the focus needs to be on wait times. Productivity is just a means to getting to those access wait times improvement and a better patient experience altogether. And another topic is it's pretty hard to talk definitively about compliance on these tiny little 1%, 1.2% numbers when it's not clear from the budget filings what year, what number, what final 2026 numbers. Is it budget? Is it projected? Is it actual? Which number are we talking about? So we we don't give definitive advice on whether they're in total compliance because it's hard to know which budget year and how those are being measured exactly. There's tend to be a lot of adjustments that staff, both on the UVM side and the care board side, seem to make. So from the outside looking at it, it needs to be simpler to tell whether you're in compliance without having to go through a lot of technical details that are not immediately obvious from the budget filing. One of the things that I think don't get talked about much, but one of the reasons we want expenses to come down is because UVM network has been a little behind on their capital spending. I mean, we hear some pretty scary stories about the operating room and its ability to use at a full capacity when the HVAC system doesn't work, or the doctor's office that doesn't have any, the urologist's office that doesn't have any restrooms, things like that. They're a little behind. If you look at classic financial measurement of capital adequacy, there was a real lull in capital spending between 20 and 24, and they need to catch up with that. So all the more reason they need to lower their expenses and generate a profit margin to be able to make the capital expenditures that will help productivity and other and patient quality in the long run. And I guess we didn't talk about that in this report, but I think I want to reemphasize the need to keep measuring affordability. And I think the care board is the party that has access to the right data to measure affordability. So we can't comment on what's happening in the last year or two because it's, we don't have that data, but we don't want to drop that topic, even though it's getting close to our time to stop being a part of the process. It's very important for someone to be measuring affordability every year with as current data as possible, because that's really, besides access and wait times, affordability is the other key outcome that we've been aiming for the last year and a half. So I'm hoping that that process of looking at affordability the care board will take that seriously and continue to pursue that. And we think a lot of the affordability issue has to include the other the unregulated we have to understand the role the unregulated business plays in affordability, so that we can also, maybe Blue Cross or maybe the care board or the combination, can come up with strategies for dealing with the unregulated businesses that affect affordability. We don't even know how to quantify their impact right now, but that's why we need more effort to measure on a reliable, credible basis affordability and its causes for when it's not where we want it to be. So I think that's enough from me. I'm willing to answer questions.
Yeah, same here.
Great. Then I'll open up to the board members for any comments or questions they may have. I'll go in the same order. I think it's Walsh, Holmes, Teach Out, Merman.
Great. Thank you. Thank you for being here, Mike, Nancy. And thank you for all the hard work and the memos. With memo 5, you've concluded that the network needs additional operating expense reductions. And based on your review, where the most realistic opportunities lie? Is this in administrative expense, management layers, shared services, supply chain? Could you give us a little bit more insight into what you found?
Yeah, I think we said in the memo all